Oh, it seems like he left the conversation, so I wondered did he get kicked off again? What about what if what about Miss Gibson?
Yes, I'm here.
Right. And Miss Carter? Missing a couple of people. Is Miss Carter on? She seems to have internet problems too. What about Miss Ham?
I'm here.
Miss Morales? Miss Morales, did you say something?
I'm here.
All right. Miss Sylvia?
I'm here. Good morning.
Morning. Miss Manders? So Miss Manders is not on. Miss Ledger?
Good morning.
Good morning. Miss Singh? Oh. Miss Singh? So if you all are saying anything, come off of mute, and then you can go back on mute, of course. Seem to be having quite a bit of internet issues this morning. So, Miss Austin?
Here.
Miss Taylor?
And my internet is messing up too, but it's like my Wi-Fi. I'm on my phone now, but it stormed all day yesterday, so.
Yeah. Yeah, I was thinking that may be a problem. Is it still raining out there?
I live in Georgia, and it didn't stop until like probably midnight. I don't know if it rained this morning or not.
Mm-hmm.
Yeah, but the weather said it's gonna rain all day today too.
Oh, you said windy or rainy or both?
Yeah, it's gonna be raining all day today.
Oh, you know what? It is raining.
Yeah.
I think it's gonna stop on Wednesday. Like it literally rained all day here yesterday.
Yeah,
Yeah.
but our weather forecast said on Friday. It's gonna stop on Friday.
Right. Wow. Okay. Is Miss Taylor on? Miss Lillian Taylor?
Yes, I'm here.
Yeah. So I have 4 people who didn't answer. If you're on this call and you weren't able to answer, write your name in the chat box. assuming so.
Mr. Weaver, do you get my name?
Yeah, who was that?
Out here.
Oh, all right. Did you say something?
I asked, did you get my name?
Thought I did.
Okay.
Yeah, you already answered. The only ones that didn't answer was Mr. May, Ms. Carter, Ms. Manders, and Mr. Singh.
I'm right here.
Ms. Singh, I'm sorry. Who's that? Oh, Mr. May.
Yes, sir.
So you having internet issues this morning?
Somewhat. That storm messed with my Wi-Fi and it's not as strong as it used to be.
Oh.
Comcast has to come back out here and reset everything.
Oh yeah, no, that can be a hassle.
Yes, sir.
So now I have Ms. Carter.
Professor
All right.
Lydia. My Wi-Fi is acting crazy out here. We live in St. Trina,
So where do you live?
in the middle of nowhere.
Oh, wow. All right. You in Georgia also?
I'm literally on the river.
Oh. It's very, very windy. Let's see. So what about Miss Singh? Is she, well, I see her on, but she didn't answer. And also Miss Carter. Well, Miss Carter's not on that I can see. Miss Singh, can you hear me? Like somebody got kicked off again. I don't think I have this these kind of issues with Zoom. I'm telling you. Anyway, I might as well not go down that road. Does anyone have any questions? Oh, hi, Ms. Carter.
Yes, I'm here.
Ms. Carter, did you get my email?
Yes, sir. It's okay.
You sure?
Yes, sir.
All right. All right. So I want to give you all a reminder again, just so we're clear. And that is when you're in clinical, you cannot be working. You cannot be out and about, especially when we are starting, in the morning and everything, because that will cause too many problems, and we don't want that at this juncture. We don't want those kind of problems. It has to be just as if even though we're virtual, it has to be just as if you all were going on site, a clinical site, with Professor Wittenkeller. When you're supposed to be in pre-conference, you cannot be sitting out in the car or getting to clinical 30 minutes later and that kind of thing. Because obviously she'll send you home. And she is a stickler, let me tell you. So we want to make sure that when we're supposed to be in clinical, that we're in clinical. And so what that basically means is, even though we might be virtual for the next 5 weeks, which I suppose we likely will, if you have scheduled yourself to be working, I will hope that you will go ahead and unschedule yourself, because, you know, some way, somehow things kind of come out. So we don't want you failing the course because you did not comply with that. So please manage or make sure you manage your schedule accordingly.
Do we start at 6:30 or 7?
We start at 7, but I typically you know, set the time in the system for 6:30, just so that people can you know, work out whatever kinks there is to log on. I mean, if you have the type of a setup, or your system is as such that you don't have any problems, I mean, you can come on at 7 o'clock. It's not a big deal. But I just give you that 30-minute leeway.
Okay.
Yeah. You know, forgive my ignorance. I knew that, kind of taking another direction. I knew that the EAQs, because I've seen this happen, of course. I knew that you can copy and paste the question into Google and come up with the answer in Quizlet. So I would typically not, and that's fine to get questions from those areas, you know, EAQs and, you know, and otherwise, especially as long as we're sitting on campus and we're actually taking a test. That's fine. Unfortunately, virtually, people might be more tempted to, you know, Google the question at home and come up with the answers and whatnot.
I thought you said that it documents if you left the website or not.
You know, it does.
So
Here's what it doesn't document, though. Depending on your resources, maybe I shouldn't say this, but you know, you all are pretty savvy. I mean, you all are no dummies or anything. So if someone has 2 computers, you know, like me, I have 2 computers, and if I'm a fast typer, I can sit here and type in that question and Google it on another computer, and it won't show that going away on the primary system.
I don't think you have that much time to do all that.
Well, that would be nice. That would be nice. These things kind of come out in staff meetings and those kinds of things. And, you know, I won't lie, it does concern me, but not as much. But, you know, it does come up, because I didn't realize that the test bank questions, just like the EAQs, can be Googled. So I won't make any accusations, even though I know it may kind of sound like I'm making an accusation. But I just want to make sure that you all don't get caught with your shirt off. Go ahead.
Yeah, but Professor, you cannot copy and paste it. The way you set up the computer, you can't copy and paste the EAQs to go Google it up.
The EAQs?
Yeah, we cannot do that.
That's strange, because I was able to do it.
We can.
I think because you did set it up, but for we can't copy and paste it. So
Yeah, we can't copy and paste from our end.
Yeah, the EAQs we are doing right now, we have to look at read our book. And that's why you see, like, sometimes you see we get like a lot of multiple questions wrong. And the EAQs will have to give you like more questions to.
Right.
for you to pass it. Yeah, but we can't copy and paste it.
Really?
Yes, sir.
I wonder, is that only,
It's been logged, so
what was that?
I said, yeah, it's been logged where you can't copy and paste.
From the EAQs?
Yes, sir, and it's all the classes.
Yeah, everything.
I wonder, is that just on the instructor? You know, I've seen a student do it before. That's
Yeah,
weird.
You can't copy and paste.
You
Yeah.
used to be able to copy and paste, but now you can't copy and paste no more.
Is that, well, you all are chiming in as a group, so maybe something changed. Well, you know,
it's like as a whole, Concord did it.
yeah, it might be.
Last semester, you could have done it. I used to make Quizlets out of my own like questions. If I didn't know the ones that I got wrong, I'd copy and paste and make Quizlets.
Well, that would make sense. Well, even so, even if you can't copy and paste, if you type well enough, and that's one of the reasons why we try not to give too much time, but adequate enough time. And I want to give you the amount of time you need, just like if you were taking state boards. I don't want to, in other words, if it's a minute and 20 seconds per question, I don't want to give you, 50 seconds, you know, because that's kind of, it's cheating you out of your time, and it's not, it's not consistent with, you know, NCLEX. Or a HESI for that matter.
And I'm a slow.
Yeah, what was that, Mr. Grilla?
I said I'm a slow reader, so 50 seconds ain't gonna cut it for me.
Exactly. And there's nothing wrong with being a slow reader. I mean, you still do very well. So, you know, as we know, there's nothing wrong with that. Yeah. Now, as a side note, if you want to really be a fast reader, then you just continue to do a lot of the reading that you do, you know, your textbook reading, and that will increase your reading speed, believe it or not. Side note. But I'm not assuming or insinuating that you don't read, but because obviously it seems that you do. But I know when I was in high school, I hardly read, I didn't even read an entire novel, you know, and surely didn't know how to write, you know. It wasn't until I, you know, of course, went in the military and started reading more, and of course, college and so forth, start reading more. And I'm the kind of student, I read everything. I don't care what it is. I read the whole thing. I don't just skim. I think I told you guys that I don't skim. And I found that over the years that my reading has picked up, and I can, you know, read fairly quickly. You know, when I have to do my textbook reading, I can read pretty quickly. And you all want to be able to do that, especially when you take state boards. You want to be able to sit there and have the endurance to do the reading. It may cut off at 75, but if it doesn't and it goes to 200 questions, I believe that's the max, isn't it, today? I have to go back and look at that because it changes. With the pandemic, I think it was less questions, but I think they may have gone back, or will be going back, at least by the time you guys get there, back up to as many as 200 plus questions. And you don't want to tire out. It's like sometimes I look at some of you all's tests, and in the beginning, you all do extremely well. And let's say if there's 50 questions, and then by the time you all start getting to maybe 30 something, 40 something, then you start missing questions. And I have to wonder sometimes, is that because you got tired out? So if you want to build your endurance and build your reading comprehension, understand how words are used in various contexts, and get those details from your readings and what have you, that I can't go over every detail, as you should know by now, then reading is going to be your best friend. Trust me. Even with the focus sheets that I give you all, if you all just, you're going to cheat yourself if you just focus on the focus document. I still say read everything, but when you get to the focus areas, that's when you want to heighten your attention, your awareness to those areas. But make sure you're doing all your reading. All right, you'll be glad you did, believe me, because you only want to take state boards one time and that's it. Did you all get my my announcement about delegation?
Yes, sir.
I mean, I know, y'all probably say, well, darn, I got too much to read already. Why is he sending me this? I try to send those little helpful tips out and don't want them to be too cumbersome to you all, but that the reading it should be fairly quick. But just to kind of spoon feed you, kind of piecemeal it to you all. So I'm not giving you like a total large journal to read or a 10-page chapter to read, but just something real quick and easy. Go through it, get an understanding of it, or at least get familiar with it, and then move on to whatever else you were doing. So that's the reason why I tend to do that. And one thing about state boards is it will test you on delegation. All right, so you want to be as familiar with delegation as possible. And of course, delegation is very important. Even though, oh, go ahead.
So I was doing my EAQs and I came upon a question about prolapse. And long story short, had a patient and she said, my bladder fell. And when she stood up, you technically seen like a little pink thing coming out. Wouldn't that be like a thorough procedure?
Like what kind of procedure?
Thorough? Or you just put it back in?
I just put on some gloves and put it back in. Yeah. Because those structures that held, you know, that those portions of your body in place are weakened for whatever reason, and they just kind of fall through, and you actually are able to visualize it. So yeah, that's mostly a clean type of thing that the nurse can actually do it, and they're probably even taught to do it.
So would the patient have to stay there for a certain amount of time?
Would they have to do what now?
Lay there for a certain amount of time?
I'm not sure exactly how long or if bed rest would be required. You know, because I'm assuming that there's certain acts or certain activities may cause that to happen. I'm thinking maybe straining could also cause that to happen, but yeah, I've not really looked at that in quite some time. I'm not, you know, I guess the OB or women's health type, I guess, which is, I think, one of the reasons why I chose adult health too, you know. But that's something I'll look at and I can get back to you. Because it makes me wonder, as you ask that question, do they teach the patient to do that as well as the healthcare provider? I mean, you can't just keep running to the doctor's office to have someone insert, you know, that portion of your organs back into place, if you will. Anybody else have any experience with that in the clinical or practice setting, or maybe somewhere where they work?
Yeah, I've been patients with it, but they can do it themselves. Whenever it comes down, they'll push it up themselves.
Yeah, that would make sense.
And they go about their normal activities.
Yeah. Right. Yeah, because I would imagine all that pressure, it would even cause incontinence and so forth. So they would have to be able to insert it insert until they have it repaired at least. You know. Yeah. Yeah, that's a tough one. One of the things I want you all to understand about delegation is to, you know, your hospitals, they will have written policies and procedures that you will have to hopefully have time to read, because I don't, you know, in most cases you not right off when you first get these jobs, you may not have time to read that information. But it is certainly important for you to know what it is your patient care tech or your nurse's aide, whatever they call them these days, what they're able to do and not do. All right. It's kind of hard for me to sit here and really get into this full-on thing about delegation, since it seems like in many of these organizations, you're doing most of the work yourself as the nurse, kind of like primary nursing. And, you know, you just don't seem to have enough ancillary help or unlicensed assistant personnel. You seem to barely have them around, or you may have one for the entire floor. So it's like, do you sit around and wait for that person to come and take your temperature, or do you do it? You know. So just make sure you're reviewing your policies and procedures, advising you or informing you on what they can and cannot do. And even if the policies and procedures say that, for example, a tech may be a couple of weeks on the floor, and they may have had training inserting Foley catheters, and the policy says that they're able to do so, but you should know what the skill level of that person is. I mean, just because you can do a thing, you've been trained to do it, if you haven't had enough repetitions or practices with it, they may still need your help. Or the help of one of the other techs showing them how to do it until they become more proficient. So don't just assume that because the policy says they can, that they know how. So you know how it is when you're in school. I mean, you get to do some of these things maybe a time or two, and then you may not see it again for another 3, 6, 8 months or whatever. So. Yeah, so you certainly want to know what you want to know what the unlicensed personnel are able to do, and obviously know what you can do. The thing about it, I always used to say, I can do what they do, but they can't do what I do, you know. And a lot of that came about when sometimes you get some of your techs, they may complain that, you know, maybe you're not doing, as a nurse, you're not doing enough. I mean, there's always enough for us to do. It's enough for everybody to do, really. But we as nurses, we're doing so much, you know, and sometimes the tech, I guess they feel like, you know, we're not doing much of anything. And sometimes I guess that is the case. But we can do, we are trained to do everything, basically, you know, so. They cannot expect, you both are not on the same level, in other words, so they need to put that out of their mind. So as far as right task, just make sure you know what the policies and procedures are. And also, as far as right circumstance, these patients, they have to be stable for you to delegate certain things or certain tasks to your unlicensed assistant personnel. All right. And you have to know if you want to assess the situation. You want to know if it is appropriate to delegate whatever the task is to the unlicensed personnel as well, or the UAP. Make sure you understand what the situation is and if it's safe for them to do so, because it's all about safety, protecting the patient from any harm. The other one here talks about the right person, the licensed nurse along with the employer and the delegatee is responsible for ensuring that the delegatee possesses the appropriate skills and knowledge to perform the activity, which is something I've already talked about. So, and you may have to do a little training with them. I mean, don't get to the point where you say, where you get frustrated and you say to yourself, I don't have time to do all this teaching. I'll just do it myself. Take the time, you know, and show them how to do it. And that way they'll have no excuse when you ask them down the road to do it. They have no excuse in saying that I haven't been trained enough on that. I'm not comfortable with that. So just take the time to show them what to do. All right, it talks about the right directions and communication. All right, and it says each delegation situation should be specific to the patient, the licensed nurse, and the delegatee. So, and of course, with all of your training and the knowledge that you acquire from this program, hopefully you should be able to determine what is appropriate, and that it is specific to that particular patient as well, because there are individual differences that we have to keep in mind as far as each delegation situation has to be specific. So it's not like a one-size-fits-all, but basically, we have to, the situation has to be very specific to all parties involved in the task. The licensed nurse is expected to communicate specific instructions for the delegated activity to the delegatee. The delegatee, as part of a two-way communication, should ask any clarifying questions. This communication includes any data that needs to be collected, the method for collecting the data, the time frame for reporting the results to the licensed nurse, and additional information pertinent to the situation. So again, all these things we want to make sure we're teaching your UAPs, so you can make sure you're getting the right data from them as they carry out the procedure or the task. If you're a patient care tech, and I think I mentioned this before, especially over at Shands UF, I mean, these techs can do all kinds of things, from dressing changes to IVs to drawing blood to AccuChecks, wound care, you know, I mean, they can just do a slew of things. When I was over at Mayo Hospital, there was a time where I was in ICU, but there was a time they would at least measure your urine output, you know, do your vital signs, you know, and a slew of other things. But then all of a sudden, it turned out that they were only doing bed baths, you know, if you can find them, and temperatures, and the temperatures went away, and you started doing that on your own. So it just really depends on where you are, you know. Sometimes nurses can be a little territorial about sharing tasks. They feel like, well, and there's kind of a point to this. If we allow the PCTs to do darn near everything, then they won't need us. So in other words, instead of needing on the floor, you may require 10 RNs, but if the techs can do just about everything the RN does as far as the skills or whatnot, you know, these corporations, they may cut that thing down to 5 RNs and just put mostly techs on the floor. And I'm not saying that that doesn't happen, you know. So there is a point there. But I think from a reasonable standpoint, they should be able to do enough task that would take the burden off of us. Your delegatee must also understand the terms of the delegation, and they must agree to accept the delegated activity. So, and with that in mind, I'm thinking more of how comfortable they feel carrying out the task. Like I said, if I only had a Foley catheter insertion, you know, in my class, and not a whole lot on the floor, then I might feel, you know, uncomfortable, and therefore I might not accept that task because I don't want to cause the patient any injury and whatnot. And especially when, especially for you you guys, you men on this call, if you have to do a Foley catheter on a woman, for example, when you think about the urethra of a woman, it may not be, you know, like when you take the catheter, you can go in straight. It may not be situated straight. Sometimes it's located just beneath, not all the way in the vagina, but kind of like just beneath, you know, that area. But from an anatomical standpoint, it's not where you might think it is. And it can be quite a task trying to insert a Foley. So you may have to get that female nurse or tech involved to help you to figure out some of these differences, if you will. Sometimes in those situations, you may have the patient to, if they can, you can have them pee. And when they pee just a little, you can see where the urine is coming from. And then, you know, because, you know, urine is sterile anyway. And then you'll know where the urethra is located. So, but they should feel, again, they should feel comfortable with the delegated task. Now, this is a very important one. The licensed nurse should ensure that the delegatee understands that she or he cannot make any decisions or modifications in carrying out the activity without first consulting the licensed nurse. So you don't want them to change anything. I mean, I do realize that judgment can come into play, and you may have to, that brain is really coming down. You know, they may feel tempted to kind of alter some things, but it cannot be altered in such a way that you're basically just more or less changing the task. Because for that specific patient in that particular situation, what you're changing it to may not be the right thing to do. You know, and you could, again, cause harm to the patient. So whenever things need to change because, you know, maybe something happens, the patient has become a little unstable or whatnot, and you decide to do something maybe totally different another way, then your delegatee must understand that they should consult with you so that you can further clarify and change the plan or the task or whatever that needs to be done. So make sure they're not taking it upon themselves and just making significant changes, in other words. And so we also talk about right supervision and evaluation. The licensed nurse is responsible for monitoring the delegated activity. And again, responsible for delegating the delegated activity. You don't want to delegate an activity and then you go on about your business and don't worry about what you delegated for the whole day, because it is our responsibility as nurses to go back and to see if that task is not only completed, but we are also looking at the outcomes. What was the outcome? You know, that's what we do as far as the nursing process. evaluation. We have to evaluate the outcomes to see how the patient tolerated the procedure. Even if they do insert that Foley catheter, we want to be able to go back and say that the patient's vital signs are stable, they tolerated the procedure well, no injuries, because you know sometimes there's these patients can have a traumatic Foley insertion. You know that the delegatee may have had difficulty inserting the Foley and cause some trauma, especially in the male. You know when the patient has BPH or an enlarged prostate, and you can't just insert a catheter or you kind of forced it, and there's some trauma. So you want to be able to evaluate these or the outcomes. All right, and also you have to make sure your delegatee understands that they should be communicating. It should be two-way communication, but they must certainly make sure that they're communicating with you about that delegated task. All right, and as a licensed nurse, be ready to intervene. Be ready to step in and take over the task, especially when it requires the skills of an astute, skillful licensed nurse. Remember, you all will have the higher level of education and training, so you are responsible. I believe that. All right, and of course, lastly, just making sure that you are properly documenting the task that is carried out. Remember, in nursing and probably just about in any industry, if it's not documented, then it wasn't done. Even though it could have been done, you may very well have done it. But if you don't put it on paper or the electronic system, then it would be assumed, especially in the court of law, that it has not been done. So make sure you're documenting the task at hand. Yeah, and sometimes you all get these questions on your tests about delegation. So it is part of your it's part of your training here in nursing school, knowing what you must do as far as delegation, what your responsibilities are, the delegatee, and so forth. So you want to certainly make sure you don't just gloss over this information because you will see it on state boards and it's certainly in the practice setting. And you want to make sure you have a thorough understanding of what it is you can do and what they can do. And as I said, you can do it all. We can do it all. And never think that just because you are a nurse or even a nursing student, that when you get in the clinical setting, and even if they do have some techs, standing around or on the floor, you're not too big or too high to give a bed bath or to do tasks that would normally be delegated to them. You're not too big for that. If the tech is tied up doing other things and the patient is lying in stool and urine, don't get into your mind that, well, I'm a nurse and I don't have to do this, I don't have to do that. That's for them to do. Don't do that. Because you wouldn't want your family member lying in that stuff for a long time either. And all it does is it breaks down the skin and causes further problems. So again, we can do everything. So we're not limited. But in today's climate, you may not have enough ancillary. When I say ancillary, I'm referring to the unassisted or unlicensed assistant personnel. So all I'm saying is be ready to do it all, because that's kind of the way it's set up. And that's not to say we don't need the UAPs. We really do. on the floor that I worked on, the nurse manager, she was Filipino. And she hired mostly Filipinos for that floor. Yes, I heard HR did say something about that. But that's not the reason I'm bringing that up. I bring that up because if you look at a lot of the, and hopefully I'm not coming across as a stereotype, but if you look at a lot of the Asian or Filipino nurses that comes over here, they're pretty small. And on the floor that I worked on, I mean, sometimes you have these patients that weighed 400, 500, 600 pounds. And you can imagine someone of that, one of the Asian nurses of that stature, they're having to lift these heavy patients. And it was pretty rough, let me tell you, so, and sometimes we just didn't have enough techs to help lift these patients and whatnot. So you're trying to get help from wherever you can get it, but it certainly would take a team effort in order for you all to get the job done. And hopefully that's the environment you all will be stepping in. Hopefully the charge nurse or management, hopefully that's the culture, where you're helping each other out. Because as I said, the executive leadership, they are not going to give you enough help. And so the only way you can be successful in those types of environments is that you have to develop the attitude that you're going to work together. And I hate to say it, but sometimes the charge nurses, they're not doing what they're supposed to do, and they let the tech just roam free, doing everything else but what they're supposed to be doing. These folks are on other floors, shooting debris, maybe outside, whatever, or sitting on the computer, looking at Amazon, hiding.
That experience?
Oh, say again?
You had a bad experience?
Oh, have I? Well, I've been a nurse for a number of years, and I've seen this time and again. And I have been a charge nurse, and I want to say that way back when, I did make sure that folks were doing what they're supposed to do. But I tell you, sometimes they're just not doing what they're supposed to do. They just get lost, and you're working your behind off, trying to take care of these patients, and these people are off doing whatever they're doing. And I just feel like, you make everyone accountable, But yeah, I've experienced that many times. I mean, there was this one young lady, she would come on in the morning and she was a tech, but she would basically be telling the nurses what to do. She was just that bold. And then she's on the computer, like, they're coming on at 6:45 and maybe about 7:15 or something like that after she gets her little report. She's online looking at shirts, all this work on this floor that has to be done. And I mean, it could be very busy in the acute care setting, but no one called her hand. I think there's this one nurse, his name is Romeo. He's a Filipino nurse. He called her hand. And I want to say she accused him of some kind of, I don't know if it was sexual harassment. It was some kind of harassment. And the manager somehow, I guess, didn't I don't want to say take his side, because it's not about taking sides. It's about investigating the situation and finding out what's what and making sure you fix the problem. But somehow the way it turned out, he ended up leaving the unit, because of how the thing got turned around on him. And I've experienced the same thing with this particular manager. So what does that tell you? Some people are just not good leaders. You know what I mean? No shade, but yeah. Yeah, I had a situation before when I came on, because, sometimes what would happen, I was in the unit, and it was like usually 2 to 1, maybe 1 to 1, depending on how ill the patient is. And one of the nurses, she had to take her patient off the floor to CT, I believe. And so I was told to go ahead and take on her third patient until she got back. And, got a patient stable and everything, situated. So I'm running around, and I'm running from one room to another. I mean, it was ridiculous. And so this nurse came back with her patient, and I worked that night, so I want to say about maybe 9:30. The patient was already back in bed, looking all nice and pretty and clean, and she's sitting there on the computer, doing her thing and whatnot. And I mean, everything was just really nice and sweet for her. But I'm still running around from one room to another. And this is the kind of foolishness that you deal with on the floors and whatnot, as a nurse. And so the charge nurse who gave me those instructions about taking on her patient, she went home early that night because I guess we were overstaffed. And she, someone else took over as charge nurse. And so I told them, I said, hey, I'm supposed to give this patient back, you know what I mean? Because I was really busy anyway. And now I have 3 patients, and she's sitting on 1 patient. And then I'm told, well, I don't know anything about that. Are you kidding me? You don't know anything about that. First of all, you don't need to know anything about that. I'm sitting on 3 patients, and she's sitting on 1 patient. How does that look? All right. So you all may say, why do we need to know this? Because this is the craziness that you'll experience as a nurse. And believe me, it threatens your license, Well, anyway, so, I just kept on, doing what I was doing, and had a couple of patients crashing, and someone else who needed AccuChecks every 1 hour. And it was ridiculous. Man, getting out of bed and darn near injuring himself. I think he did injure himself, but we had to end up doing like a slow cold and intubating and putting in lines and all kinds of things. And anyway, it was a really crazy night. And I think about maybe 2 o'clock in the morning or so, and I was fuming. Let me tell you, I was really, really upset, But you don't want to work so hard for your license and then you lose it because somebody, didn't know how to be a good leader. So they saw how upset I was, but they let that thing drag on to about 2 o'clock in the morning, and finally decided to give the patient to that young lady whose patient it was before in the first place. And do you all know that she was mad because she had to take her patient back? I mean, can you imagine? Yeah, so she had to take her patient back, and she was upset. She was really upset about that thing. And so somebody convinced me to write a letter to the manager, the same manager I was telling you all about. And I did against my better judgment, because I knew what type of manager she was. Don't seem to investigate nothing, but just take whatever they say, which she did eventually. And of course, I got to the point and I told her, I said, I'm not going to sit here and go back and forth, because first of all she had to do was look at the assignment and saw that I had 3 patients and this woman only had 1, and the patient was not severe. Well, I'm not saying the patient wasn't, the patient didn't require a one-on-one, she could have had another patient along with that one. I mean, you could easily look at that and know that, this is the situation, and you need to, judge it based on, what is before you, and whatnot. So, so anyway, I told her that I wasn't going to go back and forth with, he said, she said, because they went back as a group and lied and told her that I was online looking at stuff on the computer I shouldn't have been looking at, and I didn't have any time to do that. If anything, I think what I was doing and what they saw me doing, which obviously they apparently didn't know what I was doing, I was trying to document, because, you know, you'll run into this too. You don't want to, sometimes you could be so busy doing tasks that you're not able to document a whole 12-hour shift now. You're not able to document until 5, 6 o'clock in the morning. And there's a lot that would have happened during that time. And it's very difficult to remember everything you did. So, you know, you try to get, you know, sit down and try to document as much as you can so that, you know, it just won't all catch up with you all at one time. It's just too daunting, let me tell you. But anyway, like I said, she took up for them, and I was not going to play that game, you know, because I was a PRN anyway. So I was kind of like the stepchild, if you will. But this was the kind of, you know, this is the kind of craziness that you guys will have to deal with. But you know what? Stand up for yourself. What I probably should have done, what I should have, instead of walking around kind of mad, and I guess I can be a little passive and not make waves. Now I can, let me tell you, you know, but that time I guess I didn't feel like making waves. But if I had to do that in the future, make sure you get the, they usually have a supervisor over the facility at nighttime or even during the daytime, but on your shift, get them involved. Because I'm pretty sure if that supervisor would have saw that, they would have intervened appropriately and changed that situation. And I would have been running around like a chicken without a head and whatnot. So just remember that, get the supervisor involved, you know, because some of these people, they will take advantage of you, and they will dump on you, and they will put your license at risk. So anyway, I know that was kind of long, but just want you to be aware that it can be pretty unfair at times. Let's see. Does anyone have any questions or anything they want to add? Any experience similar, or, you know, anything? Something I want to show you all. All right, so not that. So I know this coming Wednesday, you all will have your urinary test exam. So that'll be your second exam. But of course, as you know, during your clinical, I like to do concept maps on what we'll be covering next. Our next test would be on the endocrine system. Can anyone give me a basic summary on how they think the endocrine system works? It's a weird system, you know, very sophisticated, actually. I shouldn't say weird, but really sophisticated system. Can anyone give me an idea of how it works? I know it's difficult to read ahead, you know. All right, so nobody. So I'll just go ahead and Ms. Singh, all right, go ahead.
The endocrine glands releases hormones,
All right.
Isn't
which
that
Now,
which
too much
helps
tofu?
control the mood and like growth and development and weight. The organs work. Is that correct?
yes, it does.
Or
Well,
somewhat correct?
oh, yeah, no, you're correct. I
But
mean,
mostly it regulates metabolic
metabolic
tongue tied.
activity.
Yeah.
All right.
Metabolism, growth, and development.
Yeah, those are some, yeah, you're right. And those are the couple of things that they do. They actually regulate a whole lot of different
And then
processes.
the sexual function and
all,
reproduction,
all that. Right.
all of it.
All right. Good. Now, let me ask you this. So are most of those functions, do most of your functions come from the anterior or the posterior pituitary gland? That's a tricky one. Kind of hard to remember sometimes, but if you remember one, then the other one is easy to remember, and I'll show you why.
I definitely remember one.
Yeah. All right. I'm going to share my desktop with you all because this is what we'll be working on today. So, but I want to share this with you all. Let me give this a few seconds or so. I did a lot of cleaning this weekend, and particularly in my bedroom. My closet, well, some of you probably don't have carpet, but I have carpet on my floor. It was so dusty. You know, I should have wore a mask or something, you know, but I'm a little exhausted from that. I mean, it was just really a lot of cleaning. You know, I hate to just let stuff like that accumulates all at one time. Anyway, didn't mean to go. It just kind of came across my mind. All right, so you all see this particular picture where my mouse is moving.
Yeah.
It's a little small. I was trying to, let's see, you know what? Let me do this. Copy image. I'm gonna see if I can put this on a Word document. I think that's how I did it before. That might, y'all may be able to see that one a little better. Let me see. Oh yeah. All right, let me try that one. Give it a few seconds.
Yeah, that's fine.
All right. Now, here's what's really strange about this system. All right, so first of all, this is your hypothalamus. All right, and it does control your pituitary gland. You know, the hypothalamus, as we know, is a part of the brain. So your pituitary gland consists of two lobes. You have the anterior lobe here, and you have the posterior lobe here. And this is just your anatomy and physiology. All right. One way to remember which one has the most functions is that, of course, if you look at the anterior lobe, you see these arrows and how they point to all these distant organs. So that would tell you that the anterior pituitary gland handles or does the most work. All right. It does the most work. And The posterior pituitary gland, it works on, it produces oxytocin. It works on your kidneys as well as your breast and uterus, or breast and uterus of women and whatnot. So very few functions, but here on this side, look at the slew of functions that this organ impacts or it affects. So one of the key things to remember here is the anterior pituitary gland, as I said, is here. And you have these distant organs, whether it be the bones, the breasts. This also controls the breast, certain functions. Your ovaries, your testes, your adrenal gland, the thyroid glands. These are distant organs. I mean, they're not even connected to the anterior pituitary gland. All right. But it is the chemicals that is released. For example, if your metabolic rate needs to increase, right? So the anterior pituitary gland will release this stimulatory hormone called TSH. And TSH, this chemical, will travel to this distant organ, which is the thyroid gland, and it will produce this thyroid hormone, and of course your the metabolic activity will increase. All right. Same here. If you want to, if you need hormones to be produced, you have your mineralocorticoids, your glucocorticoids, and so forth. With the anterior pituitary gland, it will secrete this ACTH, right, stimulatory hormone, which will work on the adrenal gland. All right. Same with the bones. Same with the breasts, the ovaries, the testes. These stimulatory hormones are released, and it works on these distant organs to bring about a particular activity. All right. For example, here as well, ADH. Can anyone tell me what is ADH? What does it do? What is the function of it? When it's stimulated, what is it telling the kidneys to do? Hold on to fluid or excrete fluid?
That's when it tells the body you need to retain some water, so it releases the antidiuretic hormone.
That's it. That's the key word, anti, right, Mr. DeGrella?
Yes, sir.
Right. So see, it's almost like Mr. DeGrella put a little emphasis on anti-diuretic, because diuretic would mean what? Pee. Anti-diuretic would mean against peeing, so to speak, or not to pee, right? Because your body might say you need to hold on to more volume, because maybe you have this. And believe me, I'm not jumping here, but does anyone understand negative and positive feedback loop? Explain that to me, anyone. Because that's what's all involved here with these hormones, the negative and positive feedback loop.
Isn't that homeostasis?
It does have something to do with homeostasis. And you probably picked that up because I said negative and positive feedback, because it can't be one or the other all the time, but it's that balance, right?
Yeah.
All right. So think about it like this. Your body is constantly monitoring these hormones within itself, right? And If the levels are low, your positive feedback loop kicks in, and it's basically saying you need to stimulate, this organ for more release of these hormones. So that's the positive feedback loop. We need more. We need more. Once the hormone reaches a certain level, the negative feedback loop kicks in and says, all right, the levels are enough, stop. All right. And so then when those levels begin to fall again, the positive feedback loop kicks in and says, all right, you need to produce more of that hormone. Again, you reach that point and the negative feedback loop kicks in and says, all right, stop. That's enough. The problem with a lot of these endocrine disorders is that negative or positive feedback loop is broken. All right. And so there are specific treatments or care that has to be initiated in order to fix that problem. So for example, with the thyroid gland, metabolic activity, all of our cells are involved in metabolic activity, all of our organs and tissues and what have you. And in order for these organs and tissues and cells to carry out their metabolic activity, we need enough thyroid hormones. And so when enough of those hormones are at a more normal level, if you will, then the negative feedback loop is at play. But again, once those levels begin to fall, then a positive feedback loop kicks in. Is that difficult for anyone to understand what I just said? All right. So with the ADH, let's say if your body is detecting your fluid volume is decreasing, the negative feedback, the positive feedback loop will kick in and the hypothalamus will send instructions to the kidneys to say, all right, hold on to volume. All right, and then you'll hold on to volume. And so that's how that essentially works. The same with the anterior pituitary as it relates to the breast. I mean, if you want to produce milk, for example, you need so much of that hormone on board to make that happen. So again, that positive and negative feedback loop will kick in. So now, trying to think. As far as our concept maps for today, what I wanted you to do is work on one disorder, but when I say one, I mean the hypo and the hyper. And here's what I mean by that. So there'll be, before I say that, let me check something right quick. So I want to make sure you will have time to do it. Like I said, this is a fairly strange system in how it works. Not as difficult to understand as, let's see, I'm on 15. Not as difficult to understand as some might think. But that's why I went through that brief explanation of what is actually going on. Because the idea is to make sure you understand what that system does. I actually said I was going to do this on another one, on another topic. Let me see how much this one is. See what page. Because I think you'll find with some good exposure to this now, it should help you all greatly when I really start talking about it. See, this is hyper. Oh, this is not much. All right. So what I'm going to have you all to do is you will work on hyperpituitarism. Hypo and hyperpituitarism. Starts on page 1245. All right. Now, the reason I want you all to do this particular one, all right, is because, all right, so when you guys look at some of the other endocrine disorders, like let's say thyroid, hypo and hyperthyroidism, all right, when you all work on those, that's just dealing with one issue with the endocrine system, and that is a problem with the thyroid stimulating hormones, the thyroid gland. What I like about which could be an issue with the pituitary gland itself. I like the pituitary or hyperpituitarism because when we talk about hyperpituitarism, remember all those stimulatory hormones that the pituitary gland produces. Well, when these patients have hyperpituitarism, it could be one or more of those hormones that there's a problem with, if you will, whether it be hypo or hyper. In other words, you can have a problem with the thyroid gland and the thyroid gland and the ACTH, when you deal with the different mineralocorticoids or steroids, in other words. So it could be a couple of them, it could be just, it could just be, well, it can just be one, but typically it's a few of these issues. And actually, it's mostly your prolactin, your ACTH, and your growth hormone is what most patients have issues with. All right. Although there's several, but these are the three main issues that these patients might have. Let's say if all of the hormones are out of whack, which is very rare, but let's say if all of them are out of whack. It's referred to as a pan, pan meaning it involves all of them, right? Like pandemic, pan all over the world, so to speak. So in this particular case, if it's a pan hyperpituitarism, it would involve all of the hormones. But like I said, it's usually just a few, which in this case, it's your prolactin, your growth hormone, and your ACTH. The idea for you all is to get an understanding of what the hormones are doing. Understand what the what hormone it is that we're referring to, such as, all right, so we know we're dealing with the pituitary gland, and then we're dealing with, let's say we're dealing with the thyroid, then we're dealing with the TSH, which is the thyroid stimulating hormone, because it stimulates that organ, right? So the TSH, and then we're talking about the thyroid gland itself, right? So pituitary, the hormone, the stimulating hormone itself, and then the organ, the targeted organ. All right, the targeted organ in this case is your thyroid. Of course, with some of the other ones, your targeted organ can be the adrenal glands, the kidneys, the testes, the breasts, and so forth and so on. All right. So these stimulatory hormones are located in the anterior posterior pituitary gland. They're released. They travel, those stimulatory hormones, they travel to those targeted organs and make them do whatever its intended purpose. Is that confusing for anyone? Does that not make sense to anyone at all? When you think about your excessive with your hyperpituitarism, this means that many of these hormones are being produced in excessive amounts. Hyperpituitarism, as opposed to hypopituitarism, they're producing not enough. And so you think to yourself, well, if it's been producing too much, why didn't the negative and positive feedback mechanism kick in? Because if you got too much, you would have thought that the negative feedback loop would kick in and say, all right, that's enough, stop producing. Or if it's the hypo, you would think that your system would say, all right, you don't have enough. The positive feedback loop would kick in and say, all right, keep on producing until we get to that therapeutic level. And then the negative feedback loop kicks in and say, enough, stop. So that just gives you an idea of how the endocrine system works. All right. So I want you guys to create a scenario. Let's say if you do hyperpituitarism, you may want to focus on someone who has a growth hormone issues. All right. You may want to focus on that. So that patient picture, clinical picture, based on your readings, should look like that. Don't start talking, don't put as a main issue, a chief complaint, growth hormone as being the issue, but then you start talking about the thyroid situation. All right. All throughout this concept map, it should be consistent. Just a side note, if someone has a hyperpituitarism and something has gone awry as far as the growth hormone, one of the chief complaints when they came into the hospital is that I put my hat on or I put my shoes on, last night, and I couldn't fit my shoes. My feet are too big now. Even though I was lying down, my feet were, because when you're walking around all day, your feet begin to swell, and sometimes it's hard to get back in your shoes. But let's say in this case, a patient hasn't really been walking around, and they've been they had maybe their feet up or something like that. But now all of a sudden I wouldn't say all of a sudden because it happens over a period of time. It's progressive. The shoes are too small. Their hat is too small. They can't wear the gloves anymore. It's because with the growth hormone, when it's producing excessive amounts, the body begins to grow. These people can grow really tall, in stature. That the musculoskeletal system begins to just become larger. That's just to give you an example. So actually, I think I need to make sure I create you all's assignments. I want everyone to make sure that you are participating. To be quite frank, I would prefer that I would like to, as I go from one thing to another, from one group to another, I want to see your concept maps up, and that you are actively working on your concept maps together. One person, not accusing anyone, but I want to make sure everyone is participating in the process. All right. So yeah, so make sure you have those concept maps up. So as I come into each room, I want to see you guys working on them. All right, so y'all should receive some invites for group A, B, and C. I want you to be able to collaborate, to get along, to divvy up the work in a way that is reasonable, and everything. One thing you guys may want to spend a little time on, as I always say, for example, with hypopituitarism, it's not that much reading for that section, for the pathophysiology. But if I were you all, because what I want you to do is, and you all didn't do this before, so please listen up. Everyone, please listen up, listen up, listen up. In that middle section where it talks about assessment, I want you just to give me a brief synopsis as to what the patho, spell out the word pathophysiology. And I want you to give me a brief overview of hey, did you all hear me? Did I go out, or did you all hear me?
No, we hear you.
Oh, all right. Yeah, I thought when I was setting this thing up that I got kicked out. Anyway, I thought I was in another room. So I just need you all to make sure you kind of just give me I don't want a book, but just give me a brief overview of what the pathophysiology is. Kind of, if you can, explain it in your own words of what it is for that particular issue. So you'll do two of them. One would be on hypo and hyper, because I want you to see the comparison, contrasting differences, in particular the contrasting differences of these two conditions. And it's not that much reading anyway, but it would be very important for you to see those opposites and what happens when it's hyper as opposed to when it's hypo. And not only with hyperpituitarism, hypopituitarism, even though that's all you're doing for today, but the same approach, study approach, with even hyperthyroidism, and all the others. When you talk about ADHD versus SIADH, they're opposites. With ADH, or actually DI, with DI, what you have is these patients are excreting a lot of volume, right? They can't hold on to volume. They just constantly just peeing, so they become very dehydrated, right? That's the one side of that. For DI, or diabetes insipidus. No, it's not diabetes as in blood sugars, but it's referred to as diabetes insipidus. So they can't maintain hydration because they just constantly just peeing large amounts of volume of urine. With your SIADH, syndrome of inappropriate antidiuretic hormone, you're holding on to a lot of fluid. So, and although we're not doing this particular one, But with the DI, do you have problems? Are you prone to dehydration or fluid volume overload? That's a question.
Dehydration.
All right, dehydration. So for DI, you're prone to dehydration because of excessive amounts of volume. So with SIADH, are you prone to fluid volume overload or dehydration?
For which one?
SIADH. What would you all say?
Said fluid overload.
Right. Here again, and the reason I'm presenting it like this is because they're opposite. If the one, the DI, is excessive amount of urine output, the other one is holding on to volume. So think about the symptoms. If someone is in fluid volume access of overload, fluid overload, what kind of respiratory problems will they have? Shortness of breath, right? All that, just like CHF. So would your preload be increased or decreased?
Be quiet.
That's cute. Would your preload be increased or decreased in SIADH?
Would it be increased?
Right. See how we just jump to cardiac just like that? See, it's all connected. You can't forget about the others. You have to know how to be able to connect the dots. So yes, exactly. You have an increased preload, meaning now your heart, if a patient is in heart failure, will have a very difficult time pumping that volume through because the heart is already sick, right? Would your blood pressure be increased or decreased with SIADH, this full volume overload?
Increased.
It would be increased. So with that said, let's talk about the opposite. Operative word, opposite. With DI, will your blood pressure be increased or decreased?
Decreased.
And if you're in DI, would you eventually perhaps end up with renal failure, or no?
Yes, because of dehydration and all that.
The low volume, right? So, and this is how I want you guys to even look at your hypo and hyperpituitarism, those opposites of what's going on, and so that should help you all out. All right. So I think that's all I want to say. Do you guys have any questions whatsoever about the assignment?
So we can choose either or hyper or hypo.
Well, you're going to actually work on both.
Okay, we're gonna do two different ones.
Right.
Okay.
Because I want, and it's not that much reading. That's one of the reasons why I want you to do it that way. But first and foremost, I want you to do it because I want you guys to be able to see those opposites. I think it would help you significantly once you see how they both are on both ends. You know, that comparison contrast. Say again?
Can we do it on, like how you said for hypo, it's GH growth hormone? Can we do it specifically on that, or like can we take them
well,
for both and do it?
Hold on, let me see something. You know something? I would prefer you do it on the hyper and hypopituitarism because it deals with all those different hormones. You know, as a matter of fact, yeah, go ahead and just do it on that particular one, the hyper and hypopituitarism. Because what I want you all to, with that particular one, it'll teach you about the different hormones and what they do.
Okay.
So it would really be an enlightening educational moment. Now, to be honest with you, tomorrow, yeah, you would likely be doing this particular one. So it doesn't matter. Actually, if you want to do this one today and that one, the one I wanted you to do tomorrow, you tell me.
Okay.
Because you'll end up doing it anyway. So, you know, how you all want to do it?
I'll probably just do it the way you want us to do it today, and that way we can learn the different hormones. And then tomorrow I'll know more information, and it'll be
Easier.
easier to do it that way.
Yeah, I think so too. All right. Well, you all go ahead and take 20 and go ahead and get started, and I will see you all back on about 2:30. Remember, lunch is at 11:30 to 1.
Okay, see you at 2:30.
All right, folks. Thank you.
Sounds good. Appreciate it.
Thank you.